Hey everyone, and welcome to The Explainer. I am absolutely thrilled you're here. Okay, let's just dive right into this. Today, we're going to explore a sensation that every single one of us knows intimately, but I can almost guarantee very few of us truly understand how it works at a biological level. We're talking about pain. We're going to completely demystify the biology of how we actually feel it, and then we'll examine the fascinating pharmaceutical shields that doctors use to treat it. Here's our roadmap for the journey. We're going to start by unpacking the pain sensory system, look at what happens when that alarm malfunctions, and then explore the brain's incredible pain modulation. After that, we'll pivot over to treatments, looking at our first lines of defense, the really complex opioid balancing act, and finally, navigating chronic pain.
All right, Section 1, the pain sensory system. Let's figure out how this biological alarm actually works.
To really get a handle on treating pain, we kind of need to reframe how we think about it. Pain isn't just this arbitrary suffering, right? It's actually a highly evolved, absolutely vital protective alarm system. Think of your peripheral nerves as the physical wiring of that alarm. At the very ends of these nerves are primary afferent nociceptors, which I know is just a fancy biological term for pain receptors. When you encounter something like intense heat or crushing pressure, these receptors fire, sending signals straight from your tissue, zooming up this biological wire, and plugging directly into your spinal cord.
Now, what's really interesting here is that our body categorizes these pain signals using two distinct types of wires. First up, we have A-delta fibers. These are myelinated, meaning they have this little insulating sheath that lets signals travel at absolute lightning speed. These are the guys responsible for that immediate, sharp pain you feel the split second you stub your toe. But then we have C fibers. These completely lack that insulation, so their signals travel much, much slower. They're the ones responsible for that prolonged, dull, throbbing ache that sets in a few minutes later and just lingers.
Moving on to Section 2, when the alarm malfunctions, looking at sensitization and neuropathy.
So, that perfectly evolved alarm system? It's brilliant for acute injuries, but sometimes it just gets stuck in the on position. Long after an injury, the nervous system can actually lower its threshold for firing. It becomes hypersensitive. This leads to two completely wild conditions. The first is allodynia. This is severe pain produced by a totally harmless stimulus. It's like taking a warm shower when you have a terrible sunburn. Normally, that water is fine, but suddenly, it's absolute agony. The second condition is hyperalgesia, where a normally painful stimulus becomes exponentially more intense because the nervous system is just hypervigilant.
And that brings us to a truly brilliant quirk of our nervous system called referred pain. Have you ever wondered why someone having a heart attack feels agonizing pain radiating down their left arm? Well, the convergence projection hypothesis explains it perfectly. It turns out nerves from our deep internal organs and nerves from our skin actually converge onto the exact same neurons in the spinal cord. Because your brain is way more used to processing pain from your skin than your internal organs, it literally gets tricked. It mistakenly projects that organ pain right onto your skin. It's like a giant biological wiring mix-up.
Section 3, the brain's pain modulation. This is all about the mind-blowing power of the brain over pain. So far, we've talked about pain purely as a bottom-up process, right? Signals traveling from the tissue up to the brain. But we absolutely have to talk about the brain's top-down control. Take a look at this quote from Beecher's classic World War II survey. It reveals that soldiers sustained severe, literally life-threatening injuries in the heat of battle, yet reported feeling little to no pain. How on earth is that possible? Well, under severe stress or survival situations, the brain releases its own endogenous opioids, its own natural painkillers. These travel down the spinal cord and physically block the pain signals to ensure you can survive.
And the crazy thing is, you can literally see this top-down control happening in real time. Functional MRI scans map out the placebo effect, and it proves it's not just some imaginary trick of the mind. It's a very real, measurable neurological event. When patients merely expected a treatment to relieve their pain, the fMRI lit up in the exact brain regions that control those descending pain-relieving circuits. So the mere expectation of relief literally, physically alters your brain's perception of pain.
All right, Section 4, first lines of defense, diving into pharmacological interventions.
Now that we know how the alarm system works, how does modern medicine actually build shields against it? We usually start with the foundational non-narcotic analgesics: aspirin, acetaminophen, and NSAIDs like ibuprofen. Aside from acetaminophen, these largely work by inhibiting an enzyme called COX, which practically stops inflammatory chemicals right at the site of the injury. They are fantastic for mild musculoskeletal pain. But, and this is a big but, they have hard limits. Chronic long-term use of NSAIDs is heavily restricted by some dangerous side effects, particularly the risk of severe gastric bleeding.
Which leads us straight into Section 5, the Opioid Balancing Act, weighing efficacy versus risk.
When those basic first lines of defense fail, medicine has to turn to its absolute most potent tools, opioid analgesics. To see how we apply this clinically for severe acute pain, like right after a major surgery, we use something called patient-controlled analgesia, or PCA. The machine delivers a continuous baseline dose of opioids. If the patient feels that breakthrough pain coming on, they just push a button to get a pre-programmed extra dose. But here is the genius safety mechanism. A strict lockout period prevents the machine from giving another dose too soon. It allows the patient to comfortably control their own relief, completely avoiding the risk of accidental overdose.
But here's the absolute crucial point we have to understand. While opioids are miraculously effective at blocking pain directly in the central nervous system, they carry some very severe side effects. The most immediately dangerous is respiratory depression, which is a life-threatening slowing of your breathing. When you add in the long-term risks of tolerance, physical dependence, and addiction, you can really start to see why these incredibly powerful medications require constant, meticulous medical surveillance.
And that brings us to our final part, Section 6, Navigating Chronic Pain, looking at long-term strategies and guidelines.
Chronic pain is arguably the most complex puzzle in pain management. It's not just a typical acute pain that's lasting a bit longer, it practically becomes a distinct disease all on its own. And paradoxically, long-term opioid use for this kind of pain is highly controversial because it can actually cause opioid-induced hyperalgesia, meaning the painkillers literally start making the pain worse. No way, right? Because of this, doctors really have to think outside the box. They use a multidisciplinary approach, heavily relying on drugs like tricyclic antidepressants and anticonvulsants. These are medications originally meant for depression or seizures, but they just happen to be incredibly effective at treating nerve-related pain.
Because of all these massive complexities, when physicians do consider prescribing opioids for chronic pain, they rely on really rigorous, systematic frameworks, like the CDC checklist. Before a doctor even writes a prescription, they have to optimize non-opioid therapies, set realistic functioning goals for the patient, and continually evaluate the risk of harm. They're also checking prescription drug monitoring programs to prevent overlapping prescriptions. It's a highly detailed approach designed specifically to manage the risks of misuse and overdose, while still striving to make sure patients don't suffer needlessly.
As we wrap up this explainer today, I really want to leave you with a provocative question to chew on. Pain is this immensely complex biological journey, and our medical shields, while powerful, are definitely imperfect. So how do we perfect that incredibly delicate balance between our fundamental medical imperative to relieve profound human suffering and the critical need to navigate the escalating real-world risks of our most potent drugs? It is a heavy, heavy responsibility sitting right at the heart of modern medicine. Thank you so much for joining me today, and keep asking those great questions.